Good afternoon and welcome everyone. I am Lynn Goldman, Dean of the Milken Institute School of Public Health here at George Washington University. I am delighted that everyone could be with us here today. I also want to welcome the people who are joining this event via webcast. We are so glad that you are able to participate. I want to start by thanking the Association of State and Territorial Health Officials, or ASTHO, for co-hosting this exciting event with our school. I especially want to recognize a few people today. Mike Frazier is the Executive Director of ASTHO and also an adjunct faculty member in our Department of Health Policy and Management. In fact, several of our departments are now in some shape or form working with ASTHO, and we're very grateful to have such a deep relationship with this association. I also want to give a very special thank you as well to Milken Institute School of Public Health Professor Jeff Levy for working so tirelessly to put this event together. So applause for Jeff, please. I also think it is important to expose our students to what so many of you do and give them a chance to ask questions about your careers and experience. This is invaluable for our public health students as they strive to forge their own career paths. I'm also looking forward to the evening's discussions surrounding preparedness and response regarding influenza. We know all too well what can happen in communities across the globe that are not prepared. We need to push our efforts to develop better surveillance activities, better response, more rapid response, quench these epidemics before they start to spread, and certainly to develop better vaccines. I would now like to turn this meeting over to the President of ASTHO and Secretary of Health for Washington State, Dr. John Weisman. Please join me in welcoming him. Thank you for being here.
Dean Goldman, thank you so much for that introduction and for hosting this symposium. We're really pleased to be here at George Washington University. And welcome to all of you here in the room and those folks on the webcast. We're really pleased that you have joined us for this. ASTHO, the Association of State and Territorial Health Officials, is really pleased to also co-host this event. We are the national organization that represents the 59, yes, I said 59, the 50 states and the 9 territories and freely associated states, state and territorial health officials. Our work really is around supporting health agencies and supporting and equipping and advocating ourselves to advocate for health and well-being for all folks who we serve. So we're thrilled to be here to be able to talk about pandemic flu, where we are with preparedness and response, and to essentially commemorate the 100 years since the 1918 pandemic influenza. I think we have a lot to learn from history and looking back, reflecting on how far we've come, what our status of preparedness is today, where we are looking to the future, and it's important to reflect on this both from a practice, I think, community as well as an academic community. So really, really appreciate everybody being here today for this symposium. We're going to end up opening this conversation with Dr. Red from the Centers for Disease Control giving us some remarks. There will be some panel speakers as well from George Washington University and representation from industry and the Defense Advanced Research Projects Agency. So we're going to have, I think, lively conversation, discussion as we go through the evening here. And really appreciate, again, all of our speakers coming to share their thoughts, taking the time out of their busy schedules as well to engage with us. So we hope that you really enjoy the program today. And with that, I would like to welcome to the podium Dr. John Dreisner, who is my colleague in the state of Tennessee. And John chairs the ASTHO's Preparedness and Policy Committee, so comes with a great deal of work in this area and leadership in this area. So John, welcome to the podium.
And Jay, thank you. It says on the runner show I'm supposed to stay seated.
Great.
So I will do that, and I thank you for that introduction. It's an honor to be at the table with Admiral Dr. Red, who you'll hear from in a moment. It's an honor to be here with all of you, as Dr. Weisman said, on this. We'll call it the anniversary of the first H1N1 pandemic. We're with us is the man who is the incident commander for the CDC for our H1N1 pandemic of 2009, responsible for helping us all vaccinate 81,000 people, or rather 81 million people in the United States. I didn't mean to rob you of a zero, sorry. My bad. 3 zeros, yeah. I'm not good at math. So you all are getting to listen into a private conversation between Dr. Red and I. I'll reflect on a couple of things. So I've been in the preparedness game since I was a Boy Scout. Be prepared, and it's not a bad motto. In fact, I would say that preparedness and response is probably the most important responsibility that government has for its people and its population. And one of the things I say to incoming state health officials, I've been in that role as Commissioner of Health in Tennessee myself since 2011, is that the very first thing you should do is seek out and speak to your preparedness directors and their teams. Spend a few minutes with them. If nothing happens, they will appreciate it. If something happens, and it often does, you think about what occurs when new shows enter. We're oftentimes in the middle of winter. There are winter storms. For example, there are other things that can occur of an infectious disease nature. If something happens, you'll be very glad you started that relationship early, because at the end of the day, through all of my experience in preparedness, and I was a local health director in Appalachia, Central Appalachia in Virginia, with the Virginia Department of Health. Dr. Norm Oliver is with us today, the commissioner there. Currently, Dr. Marissa Levine is somewhere in the audience, a former commissioner, my colleague at the time, and we were in the midst of how are we going to get vaccines in arms in millions of people in Virginia, and it really was a partnership. It really was a collaboration. But at the end of the day, it was about the people. It's people and relationships that are the public health preparedness safety net. You need stuff, you need material, you need know-how, but it really is the relationships that make things go. And I will mention something I think is really important to the medical countermeasure enterprise, and that is fighting like we train and training like we're going to fight. So we really have to think about, in all that we do, where are our opportunities to create the relationships on a regular basis, so that, if you will, as we used to say in the Air Force, when the balloon goes up, you're not trading business cards. You know the people that you're going to be working with. In that Appalachian community, multiple counties in Southwest Virginia, we had been doing school-located vaccine clinics, influenza vaccine clinics, for several years. Because we thought it was important. During that pandemic, in a low trust of government area, we had the highest vaccination rates in our schools during that time. Eventually, Loudoun County caught up to us because they were vaccinating people in Dulles Airport, and I just thought that was unfair. So that was not fair. But in Tennessee, where I've been commissioner for a number of years, we do school-located influenza vaccine. Last year, we were in 600 schools in 74 counties. We don't make anybody do it. We encourage it. 28,000 vaccines were given. And every one of those nurses knows their school health coordinator. They know the principals. They've created the relationship so that when there's a new vaccine coming down because there's a pandemic, and we know thankfully from Secretary Leavitt, who was I think, a big B boss for you during your time as incident commander. Pandemics are a fact of life on Earth. We're going to have another one. When that happens and those relationships are already formed, it becomes a much easier task to get people to do the things they need to do to prevent that. So I want to turn it over to Dr. Red, who is the director of the Office of Preparedness for the CDC, the graduate of Emory University, an internist by training, went to Johns Hopkins, was an EIS officer, and he has a wealth of experience in emergency preparedness, and it's an honor to have you here, sir.
Thank you, John. And it really it is a pleasure to be here. I think we have actually continued our conversation from the bus into this venue. And so as I look out in the audience, I see a lot of people that I worked with. We worked together during the H1N1 response. So I'm planning to use the time as kind of a chance to reminisce. It is the 100th anniversary of the 1918 pandemic, and that event was really cataclysmic. For something that lasted that brief of a period, it was the health event of the modern era. 50 million people died worldwide, 675,000 in the U.S. I hope we never experience anything like that now or in the future. The pandemic that I'm most familiar with was kind of a different event. It's almost the 10th year, actually about 9 years, 60 million cases, 12,000 deaths, 10% of those in children. I think that the real impact, though, was in the public consciousness, that this was a health event just as the Obama administration was coming in, and it really it captured the imagination of the public, and particularly from the media. It maybe was at some point as communication has evolved, this event was part of that. It's not quite the way it is now, but certainly the 24-hour news channels that need to get a story every day was present. Just by way of introduction, we should expect more events like the H1N1 pandemic. The ability to travel and the number of people that travel globally continues to increase. About twice as many international border crossings since the H1N1 pandemic per year. The population of the world is increasing. We're at a point now where all of the growth of population is going to be occurring in cities. So kind of that inflection point between half the people living in rural areas, half in urban. Increasingly, more and more cities with over 10 million people, megacities, 2 in 1960, 40 or so by in the end of the next decade. There is also increased potential for exposure to animals with the growth of the global middle class and the industries that support that with poultry and swine, incubators of flu virus. Also, as people move into former wilderness areas, there's the opportunity for exposure to viruses that affect animals that can maybe affect people, such as Ebola. And this increased ability to communicate, mostly that's good, but there are a couple of areas where it raises challenges. The first is the ability for violent ideologies to be transported anywhere in the world instantaneously. It also raises challenge for our jobs to communicate validated information. There's so many challenges or so many opportunities for other channels to communicate information. So all this sounds like we've just got more challenges than we can deal with, but I think that the H1N1 story, if we start before the pandemic, shows what can be done. So I'm going to talk about the work that was done in the years leading up to the H1N1 pandemic, and then what happened in the first couple of weeks. And then I'll close with some of the lessons that we learned from H1N1. It is possible to get prepared for a pandemic. The Bush administration in 2005 made this a priority. Large sums of money were appropriated to being ready. To CDC, somewhere in the neighborhood of $1.5 billion. Much of that went to you guys, but not all of it. Secretary Leavitt traveled to every state. His message was, you need to be ready for this. The federal government will do what it can, but we're not going to be able to we're not going to be able to ride to the rescue in every location. At CDC, we wrote and rewrote operational plans. We exercised. We had 5 functional exercises. These were 24-hour-a-day exercises. I think in some ways they were shorter, but they were actually more rigorous than the actual event in terms of the number of hours and the number of people hours per day. And when H1N1 happened, we were probably as ready as we could be with the technology that was available. Of course, H1N1 wasn't the pandemic we had been preparing for. All of our exercises, and it wasn't explicitly stated what country it was going to come from, but there was this idea it was going to be far away. We would have time to figure out the epidemiology and the severity, and by the time we started having the disease here, we would have all that figured out. The first case was detected as part of a Navy research study, and the study was to evaluate a rapid diagnostic device that could identify H5N1 and seasonal influenza. And the result that came back from that device was an influenza A virus, but not a seasonal virus. That organism made its way to CDC, and on Wednesday morning, April 15th, about a little bit more than 9 years ago, in our weekly pandemic preparedness meeting, over the phone, someone from the lab said, "We've got this new virus. It's got features of swine viruses seen from the late 90s. We're not sure what to make of it." We didn't, no one did really. And we thought we would investigate in California, we'd make some calls, and there'd be an exposure to swine that would be uncovered. 2 days later, in a different county in California, the same virus was detected. No link between the 2 children who'd been affected. They had not had severe illnesses, and the investigation at that point hadn't identified a swine exposure. And there was kind of this feeling that this is going to be something big. At that point, we hadn't connected the respiratory disease outbreak that had been reported from Mexico, but that was something that was kind of in the background. The big decision on a multi-hour conference call was to publish these 2 cases the next week. So on Tuesday morning, 6 days after the first detection, we published a report, and there were cases in Texas that day. The next big event was that Thursday night, so 8 days after the initial detection. And I remember Rich Besser coming down looking kind of ashen, saying that he had gotten a call from the Canadians and that they had identified this same virus in severely ill individuals, people who had died or been hospitalized in the ICU, 16 cases. And that I guess from that point in, the reason I'm not going to talk much more about that is things start to get blurry.
Understandable.
There was a phone call that night with the White House and the department leadership, and that call, there were 2 questions, and I think these are the same 2 questions policymakers will have whenever there is a new and potentially catastrophic event. And the first one was, how bad is this? And the second one was, what are we going to do? And the first question, Rich answered the first question, and his answer is, he said it was 8 on a scale of 1 to 10. And of course, no one really knew. We had these handful of cases of mild disease in the U.S. and this not mild cases from Mexico. So, his idea was, we're going to make people pay attention. And the what are we going to do question, it's one of those things where somebody's going to be asked, and it turned out to be me. And I had a simple answer. I think that's also very important in these settings, is to not be too complicated. First thing I said is we need to make sure we understood what was happening, and really our surveillance and characterization work needed to continue. The second was that we needed to implement personal interventions, so things individuals could be, so treatment, hand washing, personal protective equipment, and then we needed to implement community measures. That meant making a vaccine as fast as we could and considering issues like school closure and travel issues. So I'm going to now just skip to the end. I got to know Jay very well during those months. A lot of us spent a lot of time together. And I have to say that if just one thing that was a very positive thing for me personally was working so closely with so many state health officers, that really was part of the experience. So what did we learn from this experience? And I'm going to just not talk about those 9 months of all the things that happened. First is that everyday systems were a key part of the response. And this is true for any health emergency, that the higher the capability of the public health system, the less extra work you have to do to respond to an emergency. Two quick examples. The surveillance system that we used was the exact system that we used for seasonal influenza. So it was just using the day-to-day systems. Vaccine distribution was based on a very much supercharged vaccines for children system where we had the infrastructure to do that, vastly expanded, but using that system. The second thing is that our exercising paid off, that we were able to stay ahead of the curve in knowing what questions were going to come up and how to make decisions in a timely way. A major challenge for us had to do with the whole countermeasure enterprise and the production of vaccine and really the situational awareness to know how big of a problem this was. So there was the technical problem of producing vaccine, and there was the communication problem of not being clear that that was a problem. And I think we overpromised, especially early in the response, about the quantity of vaccine that was going to be available. Communications, I think, was very important. It will always be important, and really two different parts of it. One is within the response part, and that's making sure that we know what state health officers are experiencing, that we are communicating up the chain of command quickly and accurately, and then also that we are communicating with the public effectively. I think I just want to close with two final thoughts. And the first is that in any fast-moving, rapidly changing event, the hardest thing to do and very important thing is to challenge implicit assumptions. I mean, those are the things that are going to get you. It's like the things you don't even realize are assumptions until something that you just believed turns out not to be true. The second thing is, and I think it's obvious with flu, but I think in any major emergency that is a natural phenomenon, it's important to have appropriate sense of humility about what is possible. And so a very, very bad virus would be challenging for the way our technology is today. Even if we did a fantastic job, we might prevent 50% of cases and deaths. And that's not our fault. It's just how bad the virus might be. So I know we're going to now move to the conversation mode, but thank you guys very much.
So I really liked your comment on challenging implicit assumptions and humility. Something that I thought a lot about at that time was a posture that we had in terms of vaccination, and we characterized it as an opt-in posture as opposed to an opt-out posture. And I know we talked about this a lot in the after-action period, and it occurred to me as a younger local health officer that some of the hardest to vaccinate populations, children who didn't have well-functioning families, that we were trying to get to deep in the hills and hollows of Appalachia, but that could have also been in the deep in the inner cities of urban America, wouldn't have somebody who could opt in for them. And I think that's still somewhat of an unanswered question. And we've partnered with CDC to try and do a little bit of research on that not long after the event to try and really understand what the full effect of that was. But I wonder, I know you had to think about that. The decision ultimately was to continue an opt-in posture, but I do think we need to consider that means that there's potentially some kids that will never have a vaccine opportunity because we're waiting for permission to be granted as opposed to waiting for a refusal to occur.
I think that is
easy question.
Yeah,
I know. I want to
yeah.
give you an easy one to start with.
I think so. Two thoughts on that. I think one is that communicating effectively to groups that are displaced or disadvantaged or not part of the mainstream is a big challenge, and this is an example of that. That you would just have to believe that if people really, if there's a way to meet them at the right level with a respected, trusted person, that the facts would go with an opt-in. The other is if there's there's kind of a continuum between opt-in and opt-out, and if vaccine is so available and so easy to get, it's a lot easier to opt in than if you have to drive 50 miles or you can only get vaccinated at certain locations. So I think that making the opt-in policy easier for people to access is another part of that, part of the answer to that. That doesn't change the underlying philosophy of an opt-in posture, but it could make it easier to get it implemented.
Thank you. We were also talking about, you mentioned on the bus, talking about how, people have said if you had to have a pandemic, 2009 was a pretty good pandemic to have. But I think partly because of all the preparation that we had done leading up to that, and the opt-in posture also, I think, facilitated a lack of controversy, a lack of panic. If we had been more heavy-handed, that might have created, that zeal to do that might have created additional difficulty. But while the disease, as we talked about, was not as severe as it might have been, the economic displacement, the cost of the epidemic on the movement of people and things in society probably was much less than it might otherwise have been had we not had all the conversations that we had leading up to that time. And so reflecting on that and thinking about where we are now, what do you think, what are your lessons from that time and how do they relate to this time?
Well, first of all, we are continuing to exercise against a severe pandemic scenario. We've had 3 exercises since the pandemic, the last one a couple of weeks ago. So this is something that's still front and center as the kind of threat that we need to be prepared for. And one of the things that actually came out of that most recent exercise is this challenge of things that you might need to do in a very severe pandemic to reduce transmission that would have economic cost. School closure was the particular issue, that if a pandemic were so severe that you needed to close schools until Christmas, first of all, just making that decision would be very challenging. And secondly, you'd want to do it before you really had the problem. So how do you convince people that a highly transmissible virus with a 20% or even a 5% mortality rate not causing that kind of problem right now?
Right.
So I think there's a big communication challenge there, which is really, you probably partly solve that by the work that you have to do with the decision makers who would basically see some of those costs very clearly.
I think as you said that, I also reflect on our experience with Ebola, and every crisis we've had, we've built the capacity that you referenced. From 9/11 and anthrax. Much of the development of that public health capacity stemmed from that time, and not that public health hasn't always stepped up, we always have, but I think our capacity to do that has really continued to increase. But the the issues around Ebola and people's really willingness to make some hard decisions didn't really begin to gel until our colleague, who I think is in the audience, Dr. David Lakey, had all of a sudden a case of Ebola show up in Texas. And then, speaking of good idea to talk to your preparedness people beforehand, that crystallized the mind. So there probably, unfortunately, will be some locality that bears the brunt of an event that gets other people's attention and fuels action, fuels political will.
So it was great to meet David during the H1N1 pandemic, and then to talk with him intermittently over the years. And we've actually had several, even recent conversations about what happened in Dallas. I think that the reality is a health event like this is it can be a national event, and that means it's got a political element to it. It means that we're operating in a zone that we don't normally operate. And I think that, sometimes the rules are a little bit different there. I think our job is to really make sure that the people that are responsible for making policy decisions have the facts as best we know them. And sometimes that leads to political controversy. I think that not so much about Dallas, but the issue of preventing people from West Africa from traveling to the U.S. could have really been a catastrophic event for the response in West Africa, and have actually, it could have led to a longer lasting pandemic, maybe even more imported cases because of the inability to control the source. I think we were able to make the case that the system that we put in place, that actually all of you implemented to call people who were at risk for Ebola because they traveled back from West Africa during their incubation period, that was a better solution than trying to stop people from getting on airplanes in West Africa. So that, I think that it was a political argument that this is a better alternative than that. But I think we just have to be cognizant that these are political issues, and to a certain extent, the decisions are going to be made by people who are elected rather than people that have the technical background.
That is indeed the world that we live in, and as somebody pointed out, if you want to make that decision, you can. You just have to get elected to do it, and I respect that. So thinking about a pandemic in particular, or another emerging infectious disease threat, but mostly because we're here really talking about our readiness for the next pandemic, whenever it occurs, and whatever it is. We're talking about an influenza pandemic, but that's not the only pandemic that we could potentially be faced with. I'm interested in looking back over the last 10 years or so. What are you most proud of in terms of kind of where we've come to, and then also what are you most worried about? What's the gap that as we say, that you lose the most sleep over? And you can answer those in any order that you like.
Yeah, well, I think what has been very encouraging is the main things that were challenges, and I'm going to speak specifically about CDC. We've made really great strides in some of those things that were challenges. So just an example, something that we knew before H1N1, that our interventions needed to be scaled to the severity of the event. And so there was this thing that was created called the Pandemic Severity Index, which was based on case fatality rate, which is great, except by the time you have enough deaths to know how bad it is, you're like way down the road. So it was a greght concept. And so we spent a lot of time, like, what things can we observe early that can help guide us? All of the major decisions were made in the first 2 or 3 weeks of the event. And if it takes you 2 months to know how severe it is, you've either made the wrong decisions or an uninformed decision. So another area that we've made progress in is actually a risk assessment of the virus, that when a novel influenza virus emerges, causes an infection in humans, we have a pretty good system of knowing how to map it against other influenza viruses. So those are two things, kind of, not highly technical, but very important in terms of both communicating if there is human-to-human transmission and kind of understanding when we get two infections in China, how bad is this?
Making the initial decisions and having full situational awareness.
Yeah. Now, I think that the place where I think we're making progress, but very important to make more on the medical countermeasure side. We really need a better vaccine. That we need one that is more effective, that lasts longer, and that it doesn't have to be made against every new strain. And that is kind of the holy grail of influenza. If we had a very effective vaccine, we could move from being reactive to really preemptive. So I think that's kind of the biggest area where we need to make progress.
Great.
Yep.
No one is. Oh, there's the sign. So, do we have time for any questions from the? Okay. So, Dr. McEwen.
So we were talking about public health ethics. What would have had to happen for you to have decided to opt? What would have had related to public health ethics? What would have had to happen for you to have chosen opt out instead of opt in with that influenza? And then, if you have time still, what kind of discussions did you have around the isolation we used with Ebola? We knew that those individuals were not contagious.
Apparently, your question is.
It's both. It's both. not okay to ask that one, huh? We knew that those individuals were not contagious, and I think we decided to go ahead and put them into isolation for public perception, possibly, which allowed us to continue to travel to Africa and deal with the situation at its source. But I'm just curious what conversations might have happened.
So I think that there are practical issues that make some of these ethical quandaries a little less realistic. In the H1N1 pandemic, we knew that we weren't going to have enough vaccine at the beginning. So the idea that you would make people take it when you didn't have enough for the people who did want it and had the same risk factors. The question about Ebola and I guess it's really about quarantine, and I think that this also didn't practically the ability to quarantine the number of people in the number of different locations people were going back to wasn't a practical option, and so the ability to do it meant a little bit like the vaccine thing, that if you try to do it, it's probably going to make the problem worse than the problem that you're trying to solve. I think that there is a societal right to limit movement under certain circumstances. In the Ebola event, voluntary quarantine was what was used, and there was a very rigorous process of tracking people, particularly those who were at high risk. Most of those people that were at high risk were medical providers and understood the risk to themselves and the advantages of being in close contact. So, I think that on that side there is a societal right to restrict movement, but with the philosophy of making that as least restrictive as is necessary to protect the public's health.
Dr. Levine will be our last question. Yeah.
Thank you, Mike. Thank you both. I've thought a lot about community readiness, and because of the monies we had to do pandemic preparedness before H1N1, a lot of us at the local level were able to do community level exercises. So we actually impacted the community's understanding of what might happen, and there was a sense that they knew that we were ready and they knew what to expect should that all come about. Since then, I've thought a lot about opportunities and maybe missed opportunities to prepare people for a pandemic, because you all talk about it as though it's going to happen. We all think it's going to happen. But we know that during the pandemic, people were receiving regular flu vaccination, and then they had to get an extra vaccination for H1N1, and they didn't understand that. They were suspicious of it, and it came later than the peak of disease in some cases. Are we missing an opportunity now to educate the public about flu vaccination and bring the pandemic message in so they know that there might be years where we have to have additional vaccination? And you talked about, John, doing the school vaccine for children, which was a great preparedness exercise. But I think all of us, although we're doing exercises, we deny almost to the public that these things are possible because nobody wants to talk about it. But I wonder if we could do a better job of communicating more regularly in a way that prepares people better. Your thoughts?
When there is a health event like the Ebola epidemic or the pandemic, we've got people's attention. And I think the challenge is feeding people information when they're not ready to receive it, or they're sort of on the apathy scale rather than on the agitated scale. And so maybe the opportunity that we're missing is these kinds of events occur, not influenza pandemics, but there are times when people really want to have a health message that's related to an emergency, and try to figure out how to use those opportunities when people are very receptive to the kinds of things that could happen.
One of the things that we've talked a lot about in the policy circles is what's a unifying event? What can we train to so we're ready to fight when something bigger occurs, if you will? And we have this annual seasonal epidemic of influenza, and we've lost 1,485 children over the last 10 years to influenza. And 50% of those children had no pre-existing condition, and 2/3 of them died within 7 days of diagnosis, and 60% of them died in the hospital. So I do think that there are opportunities that we're missing. There's some failures as a public health enterprise to really message that in a way that grabs people. It's people kind of shrug their shoulders that it's just flu. But I do think that there's an opportunity to harness that, tell that story. I know I'm not good at framing that. I frame it as a typical public health person. Too many people die, and we should do something about that. That's not a great way to frame it. And we need better communicators to really help us, galvanize that. But thank you for raising that. I want to say to Rear Admiral Red, thank you so much for the work that you do. The students in the audience that are public health students, really good, smart people occupy these incredibly important positions of responsibility, having to use their education and their wisdom in real time without all the information, and even years later, there's still a lack of information upon which to make decisions. And then we come into forums like this and we question the decisions that were made at the time. These are incredibly difficult jobs, and I'm just grateful that there are people like you willing to stand up and do them. So thank you, sir, for your service and your ongoing service to the CDC and the people of the United States. Thank you.
Yes, thank you for that, Dr. Red. And I must say, for those of us who worked through that, I was a local public health official at the time. You talked about day 8 being Thursday. I remember day 10 or 11, the Saturday or Sunday, when you all, CDC, held a briefing with public health officials where we were briefed on what you were seeing and noticing. And I must say, it reminds me how important those first communications are, how critical it is we get that right. And you all were spot on in modeling for us what we needed to hear and how we needed to say that. And it was incredibly professional. And you gave us, again, as John said, these opportunities, which you don't want to have a pandemic, but if you're going to have one, the opportunity to see where our plans work, where they don't work. We, in my local community, had 4 health departments in a tribe do incident command under one incident commander, which was incredibly opportunistic for us to figure out how to work that. And the learnings about, in this particular case, working with a tribe, sovereign nation, we had sort of prioritized schemes that we wanted for this vaccine, and realizing that for others, there are some things we have to pay attention to in terms of culture, in terms of acceptance, and lots of learnings there. So thanks for triggering those for us to make sure we don't forget them as we go along the way. Appreciate it. And Dr. Breisner, thanks for hosting that. All right, so next we're going to bring up our next panel, and Dr. Jay Butler, my colleague from the great state of Alaska, is going to host this part. Jay is the immediate past president of ASTHO, and welcome.
Thank you, John. Well, good evening, everyone. It's really a pleasure to be able to take us into this next phase of the discussion with a really distinguished panel who will lead us through a further discussion of pandemic preparedness. So I'd like to introduce the panel, and you know who you are, so feel free to come on up to the table there. This isn't like the awards luncheon where people are surprised.
Do I have a list to say?
Yeah.
All these people to thank.
So let me start right here to my right, your left. Colonel Matthew Hepburn is the program manager for the Biologic Technologies Office at the Defense Advanced Research Projects Agency, hereafter referred to as DARPA. Colonel Hepburn joined DARPA in 2013 to address the dynamic threats of emerging infectious diseases with potential impact on national security. Prior to being at DARPA, he served as Director of Medical Preparedness on the White House National Security Staff. So, welcome. Next to him is Dr. Jacqueline Miller, Vice President and Head of Clinical Research and Development at GSK United States Research and Development Center, where she leads a team of 33 clinicians and epidemiologists. She's worked in the field of vaccines and clinical development as well as medical affairs for nearly 2 decades now, previously with Merck. Currently, she leads clinical development at GSK on a number of our favorite pathogens, including RSV, CMV, zoster, and of course, because we're here, influenza. And right now, I don't know that he's in the room, but I want to go ahead and do the introduction, is Dr. Carlos Santos Bergoa, who is a professor in the Department of Global Health here at the Milken Institute. Previously, he was Director General of Health Promotion at the Mexican Secretariat of Health. And being a member of the faculty here, he's actually with students right now, and hopefully will be able to join us. So he is really focused on the importance of equity and development of regulatory public health function within health systems. And one of his special interests is the implication of international trade and other global arrangements on regulation to protect the population from avoidable exposure to risks. So I'm going to join you at the table, and the format for this session will be, we have about 10 or 15 minutes just for opening comments, and then we'll have a time of give and take with the audience. So starting with Colonel Hepburn.
All right. So I may try to hook this up as we talk, or we'll see if the guy who's now at DARPA can figure out technology. But I'm a physician, so therefore a Luddite. So can everybody hear me okay? All right. Hey, I pulled it off, and one of these things too to advance. I have a couple slides, but I have a couple slides in 15 minutes. I felt probably if there's one message more than anything else, is really amazing to be here. It's a real thrill. In my introduction, they mentioned that my previous role before DARPA was, my title was Director of Medical Preparedness over at the White House National Security Council staff. Started there in 2010, so it was after the H1N1 pandemic. And went from so I'm a clinical infectious diseases physician, and I did a lot of work in the biodefense and national security space, as well as a lot of work overseas, because we have a worldwide network where we do clinical research. but I was put into this role of really how do we coordinate as an interagency to prepare for the next pandemic, and it was in the aftermath of the H1N1 pandemic. And so essentially went into a place where I was working with public health really almost on a daily basis, working certainly with Dr. Red, who became one of my heroes really fast, because I think just from a purely educational standpoint, to understand how we as a government kind of addressed the last pandemic, but then how we were being proactive to address the next one. But also to work with ASTHO, to work with state and local public health. It was tremendously educational. And one of my main missions there was to look at how we did public health surveillance and prepare for the next one to improve our surveillance capacity. And that's an ongoing big problem, tough problem to solve, and an ongoing thing. But it just gave me a true appreciation of what you do, and it gave me appreciation. It's nice to have students in the audience, and I think anybody contemplating a career in public health, I can't imagine doing anything more rewarding. But what led me here, though, today was that after serving there for about 2.5 years, I had this really cool opportunity. I had someone tap me on the shoulder and said, okay, you're doing a lot of interagency policy meetings. God bless you. And so now what we're going to do is give you the chance, now that you have at least a better appreciation of what the problems are, where the gaps are in terms of our national preparedness for the next pandemic, we'll give you a chance to do something about it. And so they tapped me on the shoulder and said, we want you to come over to DARPA. And the reason we want you to come over to DARPA is that we consider pandemic preparedness, outbreak response, a clear national security priority. DARPA is a national security organization. Our mantra is to prevent technological surprise. We just celebrated our 60-year anniversary. We were created by President Eisenhower soon after the Soviet Union launched Sputnik. And what President Eisenhower said is, never again will we as a nation be surprised and therefore vulnerable. With the insight of the DARPA director, with lots of now policy documents like the National Security Strategy of the United States saying that pandemics is one of our most pressing national security threats, that's why I got recruited over there. And so it was very easy then for me to articulate, in this case, the technological surprise is not some other human being or anything else, but it's actually Mother Nature, where we are constantly being surprised. And for this audience, so for a lot of other audiences, so like, for example, in my building, I'm really the only healthcare person. I'm surrounded by scientists and engineers. So it's fun to be back home among friends, but I feel like I don't have to make the national security argument or the argument that we will continue to be surprised. I think we've already done so. But the cool part about my job, and what I'm going to spend about 10 minutes on talking now, is what can we do about it? And what I'm trying to do is leverage an organization like DARPA to complement how we as a nation, and also how we as a global community prepare for the next pandemic. DARPA, what we do is we actually invest. Our mantra is breakthrough technologies for national security. So we fund projects. And the hallmarks of those projects are 3 things. The first is that we're not duplicating effort that somebody else is doing, but rather we see that we're going to complement. And I'm going to give you 3 examples of projects. Hopefully, I can articulate that. The second is that those projects need to be very high risk and that we de-risk the technology. What does that mean if I'm not talking to engineers? What it means is that we take on problems that are really, really hard, and we make statements that people would say, well, that sounds crazy or that sounds outrageous. When I say, like, here's what we're going to do, and especially if it's a strong subject matter expertise audience and they laugh at me, then we know we're on the right track. We're supposed to be the ones that kind of push the envelope. And that has happened to me. I'm gracious, please don't laugh at me too much in the rest of the presentation. But the best part is when the fellow panelists laugh at me too. Yes, I do feel like I jeopardize my professional credibility, which I don't really care about. But I think the flip side of it is that by taking on really hard problems and by saying, really starting with what is the world that we imagine, what is the preparedness that we need to be, and then we work our way back to say, what would be possible, even if it's a long shot, for investment that would be truly transformative? And that's the third component. It has to be truly transformative. We don't put money on things that are going to be an incremental improvement of how we currently respond. Our thought is that we put money on something that it is such a breakthrough that we will fundamentally respond differently if we are successful. So we also, the D in DARPA is for defense, and so we do care very deeply, but also our organization cares very deeply about our worldwide deployed military force. And so I make the point that we are aiming for breakthrough investments for national security, how we respond globally to the next pandemic, but we also care very deeply about if we're going to ask military personnel to go somewhere, that we have an obligation to do everything we can to protect them from harm, and if they do get sick, to take care of them. That's why I wear the uniform. And the reason I make this point is that a lot of our technology is aimed at sort of quick, responsive, and often stuff that works in resource-limited settings. Battery-powered, survives in the cold and the rain and all those other things. Why is that relevant? And people say, well, that sounds great. What does that have to do with me? I mean, and I'm sure many of you represent states with rural communities, and this idea of how do you do healthcare where you may have limited resources, I think is actually some of our technologies very pertinent to that rural health medicine mission. Furthermore, one of, at least in my limited experiences, and you all could verify this, is that what's the first thing that happens in the early stages of just about any outbreak, especially once it starts to get its news coverage? Everybody, the sick and the worried, show up in the healthcare system, and our healthcare system fundamentally, although I know there are probably people in this audience trying to make this different, our healthcare system is just not made to surge. And so as our healthcare system gets overwhelmed, we're imagining that we have to think very distributed when we're talking about both detecting, understanding, and then responding to an outbreak. So let me give you 3 examples of programs, and I highlighted these because, again, I think these would be particularly helpful to your mission if we are successful to respond to the future pandemic. And the first 2 are in that category that Dr. Red highlighted of, at that early stage, how bad is it? How bad is it? Do we understand the impact of the outbreak that we're trying to respond to? Furthermore, especially this first one is addressing this issue of, okay, if we have someone who's sick, but we have another person that's exposed, what do we do about it? So we call the program Prometheus. Prometheus was the Titan associated with forethought. And this is an idea, a goal to be able to predict. And the goal here is to say, after someone's exposed to an acute respiratory pathogen, can we predict if they are going to be contagious? Most of you following scientific literature and biomedical research progress, there's a lot of effort being put into the ideas of, can we look at the host response to a given pathogen, and then early on in that process, can we say, is that person going to be symptomatic? Or if they're symptomatic, are they going to end up in the ICU? This idea of using host response to predict is not really new. What I think would be incredibly helpful, though, is not only predicting if someone's going to be symptomatic, but to try to predict if someone's going to be contagious. In this case, contagious is defined as a surrogate of how much virus they have in their nose after they're exposed. So that's what we want to do. Is that a hard problem to solve? It's outrageously difficult to solve. That's why we're in the space. But I think we can. What we're doing now is putting a significant amount of investment in essentially a discovery program, obtaining samples from patients who, after they've been exposed, but before they have lots and lots of virus in their nose, and essentially interrogating that, doing RNA sequencing and looking at cytokines and metabolomics. We're looking at wearable technology. Does it make a difference if you got a good sleep the night before or not? All of these factors, and trying to put it together as an ensemble to see if there is a signature that would differentiate if someone is going to have a lot of virus in their nose or not. That's hard. I don't know if we're going to be able to come through for you. But if we are, then the second part is that I'm probably going to need a drop of blood or so to get that. So, and furthermore, if I'm going to measure any type of analyte, I really have to do that at the point of care. You can't wait a day with flu for a lab test to come back and say, yes, this person is going to be contagious or not. So after we are successful here, cross my fingers, then we also have to work on accurate point-of-care technology. I'm actually not that worried about that. I think some of you have seen that we're putting a lot of investment in accurate point-of-care PCR and other immunoassays that you can carry that our Army medic or Navy corpsmen can carry on their missions. So I think putting that on point-of-care, if we are able to predict what those analytes are, is going to be a challenge, but maybe slightly easier challenge. Okay. Second program, this is actually a little bit less on the outrageous side, and this is more of the if you haven't been tracking this trend, I think you should. Hopefully, I can inspire you after this talk to make a couple phone calls and start to watch this a little bit more closely. So the idea here is portable ultrasound technology. What happens right now is that our special operations medics will carry a transducer and they can read it on a cell phone or a tablet, portable ultrasound. They carry that for trauma assessments, fast exams, blood in the abdomen, and a few other indications. Okay, those portable ultrasound technology, GE, Philips, is like this is already there. DARPA investment in that is absolutely zero, right? It's already there. What's the rate limiting step with portable ultrasound technology for our medics is that they have to be trained to be able to read what is essentially, at least in my mind, a snowstorm. Okay? So if they can see something in the snowstorm, that usually takes about 3 to 6 months of training, and we're training our Army medics on everything else under the sun as well. Okay? So, and in particular, which organ do I care most about in terms of pandemic preparedness? I care about the lung, right? And so therefore, but imagine if we could automate the reading of a lung ultrasound image. So we put the probe in 12 different places, and it reads like an AED. Pneumonia, mild, moderate, severe, pleural effusion, pneumothorax. That's actually not that crazy because as you guys are tracking, artificial intelligence in the news every day, everybody else in my building is working on artificial intelligence now, so I'm basically a copycat. And so, but I say, well, why can't we just use machine learning to automate lung ultrasound reading? And it turns out that we probably can, and we're getting really good performance in these initially. One of the fun parts about this too is a partnership with a group called Global Good, which is a nonprofit in Seattle that works with the Gates Foundation for global health applications, but it's linked in with Microsoft. So I get world-class machine learning experts working for a global health purpose. And obviously, if you can automate lung ultrasound, pediatric pneumonia, those types of things, we think this is a transformative technology. But this is right now. Like, we're going to be pushing this we're in image collection now. We're going to do prospective clinical trials for FDA approval in 2019. So this is a trend, and whether it's whichever, and this, the idea is run on whatever portable ultrasound is your hospitals or your CVSs or your clinics eventually use. But this is a distributed technology. Like, why not? Why can't EMTs or Uber Health, when they come to your home or something like that, do? And so, but that's not crazy, though. That's not crazy right there. Uber Health is talking about vaccine programs and stuff right now. But here's where it's cool here's what, and we haven't done this part yet, but here's where you guys may get involved in this in the next couple years, is that right now, we're getting very good at swabbing your nose and doing a PCR, and if I can do that PCR at the point of care, I can say you have influenza in your nose, right? But how sick are you, right? That's that severity question. But imagine in your real-time public health surveillance system, if we're swabbing your nose and getting accurate pathogen diagnostic, but we're coupling that with a normal ultrasound, or we're coupling it with a mild pleural effusion, or 10% of those patients have significant consolidation. So this is a surveillance tool. And when I say this to everybody else, no one gets that. But I hope this audience can sort of see that, imagine if you could do surveillance for severity in addition for pathogen diagnostics. So my last program, just to talk through very briefly, is that this is the second part. So what are we going to do about it? And I'm glad Dr. Redd again highlighted this need for medical countermeasures. Dr. Redd highlighted a really strong push that you're seeing out of Health and Human Services now in terms of a universal flu vaccine and how appealing and I would say even necessary that's what we're going to need for the future pandemic. We're not investing in universal flu vaccine. This idea is not even a vaccine program. It's meant to complement vaccination. But what we're saying is that what if we could develop a medical countermeasure that could give you near immediate protection, let's say within 48 to 72 hours after I do a shot in the arm, and I could make 20,000 doses of that in 60 days. So thank you for not laughing. But again, we started this whole program with the DARPA director coming to me and said, well, for an outbreak response, and especially for an early fire break response, for a fast-moving outbreak, how fast, how many doses do you need and how fast do you need it? And I said, I don't know. But it depends on the outbreak. But I said, okay, I'll give you a rough estimate, top of my head, 20,000 doses, 60 days. He said, make a program. So this is what we have. And it was actually, there was much more in terms of thinking about the foundational aspects. What are technology trends that could allow us to make an outrageous claim, but actually make that realistic? There are 3 trends that we're going to capitalize on this program that I think make this reasonable. We're in our first year of 4 years, but this is not a pipe dream and outrageous. I think this could be real because of 3 trends. The first is that we know that antibodies, the right antibody or the right combination of antibodies, can protect and sometimes treat you when you have an infection. ZMapp for Ebola. Now we have 3 others that are currently being used in the Eastern DRC outbreak. And there's a proud history of this in infectious diseases. So antibodies can work if you have the right ones in the right amount at the right time. And oh, by the way, most of our pharmaceutical colleagues right now are taking advantage of antibodies against cancer and against our own immune system to rev it up, checkpoint inhibitors, things like that. So the idea of making antibodies as a product, we don't have to invest a massive amount in. This is happening right now. But the cool trend that technology is allowing us is the rapid discovery of many highly potent antibodies in a very short period of time. There are multiple groups doing that. That's a fundamental component of what we need to do. So if we have a novel coronavirus, let's say the next version of MERS, can I find you an antibody, a highly potent antibody, in the period of 2 to 4 weeks? Yes. Yes. We're investing in 4 performers that can do that right now. Okay, so if I find you a highly potent antibody, well, now we're cooking, right? But the problem is that we have to produce that in sufficient quantity in a short period of time. Current technology, if we're going to brew it up in a big vat as a protein, is probably, our pharmaceutical colleagues can argue with me, but I funded some of these programs and it takes 2 to 3 years. So can you accelerate? Sure, but that's not fast enough. However, can we take DNA and make large quantities of DNA or RNA in a very short period of time? Well, yes, we can. So we have 20 years of DNA vaccine technology that's currently been out there. That DNA vaccines have been shown to be safe. The problem is they're not as immunogenic as we want them to be. But what they've done is enable the technology. So I can make a lot of nucleic acid in a short period of time. So the mix, the Reese's peanut butter cup, the chocolate and the peanut butter, is finding the right antibody in 2 to 4 weeks, taking that sequence, putting it on a piece of DNA, injecting the DNA into your arm, convincing your muscle cell that, say, for a short period of time, I need you to be a B cell, and I need you to produce sufficient quantities of that highly potent antibody to protect the patient within 48 to 72 hours after administration. We've done a lot of work in animal models to show that that can be done. We can give you a piece of DNA that the mouse muscle makes a lot of antibody, and it protects from. We've run this for 10 different infectious diseases. We're taking some of those early products into phase 1 clinical trials right now. We have 4 performers in the first year of a 4-year program where we've said you need to go start to finish and make 20,000 doses. And by the end of our program, at least some of those products will be taken through phase 1 clinical trials. So, if we are successful, maybe not tomorrow. I'm worried that the next pandemic is going to come 2 years before I'm ready. But if we are successful, imagine this as a future tool in the toolbox. Not to replace vaccination. You're still going to need vaccination for long-term protection. But this is your early fire break. Ring, high-risk populations, here's where the initial outbreak is. Put in the fire break while the longer-term vaccination strategy is catching up. So hopefully I've inspired you a little bit. But this is what we do. I guess my final point is that I make it sound like this is us, but this is actually all we're part of a team, we're part of a family, you're part of that family, this collective group that is aimed at responding to the next pandemic. Everything I've talked to you about, we frequently communicate with NIH and BARDA and our DoD colleagues and certainly with the CDC, and sometimes where it's relevant with global partners. But I do think collectively we can be better prepared for the next pandemic. Thanks.
Thank you, Colonel Hepburn. So moving from this issue of the role of expanding and emerging technologies, let's focus in on a specific medical countermeasure. So I'd like to turn it over to Dr. Miller to tell us about flu vaccines and what we have and what we might have in the near future.
Well, thank you very much, and thank you to the organizers for inviting me. I'm really pleased to be here, not just on behalf of GSK, but on behalf of industry, to talk to you briefly about the history of flu vaccine development, and then hopefully to give you a flavor at the end of the talk about where we're hoping to go in the future. So just in full disclosure, I am an employee of GSK Vaccines, and I will be talking to you today about vaccines that are currently licensed, vaccines that were licensed outside of the US, and vaccines that are not licensed but are in development. So we're here commemorating the 1918 pandemic, and I'm not going to belabor the point because I think the point about how difficult that time was already made. But as a native of Philadelphia, I really couldn't resist this picture, which is taken from a newspaper at the time. So there were 50 million deaths, as was mentioned. This came at the tail end of World War I. World War I was the deadliest war in human history, and I looked up what the estimates of casualties were worldwide. That was 40 million individuals. So this pandemic was more deadly than the deadliest war. And the picture from Philadelphia is actually mass grave burying. So there were 11,000 deaths in the month of October 1918. At the time, while there weren't the same preparedness measures, obviously, transportation also wasn't at the level of sophistication it is today. So this obviously remains something that we need to be vigilant about. So just a little bit brief vaccinology 101. The influenza virus has really two key surface antigens, and these become very important in vaccine development. So the first is hemagglutinin. It allows the virus to attach to host cells and enter the cell. And this is responsible for the H in the H classification system, like H1 and H3. Then there's neuraminidase. This is important for the virus to avoid entrapment in the respiratory mucus, and it's also important in the release of the virus from infected cells. And so this is obviously the N part, so N1, H3, N2, and so forth. So this slide will give you just a little brief overview, and I'm not going to spend too much time on it because it's obviously quite busy. But the point I wanted to make here is that flu vaccine development is not at all new. Actually, after the 1918 pandemic, there was a lot of interest in influenza virus, culminating in the first monovalent influenza A virus in 1942, and really followed soon thereafter by an H1N1 and B virus. So B, really in the 30s and 40s, the awareness increased that more than just subtype A were circulating. Then in 1958, we had another pandemic with H2N2, and at that time, the influenza A strain was switched out. Really, the modern flu vaccine era started in 1978 with the H3N2, H1N1, and B strains in a single trivalent vaccine. That was in response to the 1968 pandemic with H3N2, and that really was the cornerstone of influenza vaccination for the next 40 years or so. But starting about 1985, we became aware that two B viruses, B lineages were actually co-circulating. So that's the Victoria and the Yamagata strain. And finally, in 2012, the quadrivalent seasonal influenza vaccines were licensed. Unfortunately, though, as you see in green, the 2009 pandemic struck even before that quadrivalent vaccine came. And influenza vaccines, while they really prevent a lot of morbidity and mortality, have their challenges, as we'll see in the next slide. So question, how effective are these vaccines? And the answer is, it depends. So it depends on how well matched the strains are in the vaccine to the strains that are circulating that year. It depends on whether there are new virulence factors. It depends on whether the strains are similar to previous years and people already have a good priming response. So the CDC actually tracks the effectiveness year on year of influenza vaccines. And what you see here is between 2008 and 2017, the effectiveness ranged between 19 and 60%. So even with these moderately effective influenza vaccines, a substantial public health burden is averted, as I don't need to tell you. So in 2016-2017, the effectiveness was estimated at 42%. Nonetheless, about 85,000 hospitalizations, 2.5 million medical visits, and over 5 million infections were prevented. So again, I won't go through this slide in detail, but just to give you a sense that there are many licensed flu vaccines currently in the United States by many manufacturers. Most of them are split virion vaccines, but some of them also include high doses or novel adjuvants. There's now a recombinant protein vaccine. And once again, I'm a pediatrician by training. We'll be using the live attenuated influenza virus. And the point I wanted to make here is that the reason I think as a country we utilize the strategy of multiple manufacturers and multiple vaccines to be available is really to safeguard our supply. We actually have one of the most progressive and generous flu vaccination programs in the world. And so in order to ensure that supply, multiple manufacturers has been a strategy of the FDA. So it was mentioned multiple times earlier in this discussion that although we responded to the pandemic, it came too late. And here I would really like to acknowledge the regulatory agency in Finland, THL, for providing me with this slide. But I think this slide really nicely makes the point about what happened. So you heard a little bit about how people experienced the pandemic. For me, I was working on meningitis vaccines at the time, Neisseria meningitis. And when the pandemic struck, I was pulled off of that program and immediately put on influenza vaccines. So the entire company really was mobilized to try to develop a new vaccine to deal with the outbreak in a timely fashion. And you can see that while this happened at our company, it happened at multiple other companies as well. Nonetheless, we were too late. So really there's this large peak of infection, and who knows, maybe the peak would have gone further if we hadn't started vaccinating. But ultimately, multiple infections happened and there was not enough vaccine in some areas to go around. Other areas had too much vaccine and didn't utilize all of it. So in the United States, we actually utilized an H1N1 vaccine that was very similar to the seasonal vaccine in that it represented the hemagglutinin and neuraminidase antigens that were present in that swine flu strain. And the standard dose of 15 micrograms was given. Outside of the US, many countries opted to use adjuvanted vaccines, and I want to talk a little bit about our adjuvanted vaccine. There was one other by Novartis called Flocetria, and used a similar but not exactly the same adjuvant. So this vaccine now has been licensed in the US as a pre-pandemic vaccine. It is a split variant antigen, so in this case, it's an H5N1 antigen. But the US government actually stockpiles multiple antigens from multiple manufacturers. So there's also H7N9, there's H9N2. But in a pandemic, it's envisioned that this would be a monovalent strain that's recommended by the WHO. And what you can see is we can reduce the dose to 1/4 of the standard adult dose, or 15 micrograms. So the standard dose in the adjuvanted vaccine is 3.75 micrograms, and we include an adjuvant called ASTHO-1-3. It's an oil and water emulsion that includes alpha-tocopherol, or vitamin E, as the immunostimulant. The vaccine from Novartis included a stimulant called MF59, and that's similar to monophospholipid A, if you're familiar with that one. And then the pediatric dose is half the dose of the adult dose, so even more antigen sparing. And that's really the advantage of adjuvants. It enables you to use less of your overall antigen, and if you're making it in eggs, it's certainly a precious resource in the time of a pandemic. And it's mixed immediately prior to injection. So prior to the pandemic, we had exposed 15,000 subjects in clinical trials with H5N1. That was the virus that we thought was going to cause the pandemic. And when the H1N1 virus strain was known, we tested an additional 15,000 subjects. But the real effectiveness and safety information from this vaccine came in the post-licensure period, where over 90 million doses were administered worldwide. But since I'm the clinician, I'm going to talk a little bit about some of the clinical trial data, and I'm going to keep it extremely brief because we want to get to the discussion. But the other point about adjuvantation is that it can enable cross-protection, and that really is a huge benefit over seasonal vaccines. So seasonal vaccines, you have to get them every year because even small changes can lead to antigenic drift. So in this case, we took subjects who were vaccinated with the H5N1 ASO3 vaccine, and we compared them to subjects that got the same dose, but without the ASO3 adjuvant. And although we vaccinated them with the H5N1 Vietnam strain, we also tested them against 3 heterologous strains to see the degree of cross-protection. And what you see in the different colors are different time points in the graph. So going from day 0 to 3 weeks after vaccination in yellow at day 21, 3 weeks after dose 2 in orange at day 42, so 2 doses is considered a full regimen, and then 6 months later at day 180 in green. And what you can see on the right-hand side for each of the 3 different graphs, the individuals after 2 doses who were vaccinated with the adjuvant are able to generate an immune response in almost 100% individuals to the heterologous strains as compared to the unadjuvanted antigen, where really less than 30% achieved those seropositivity levels at any time. So what's the value? The value is that when you stockpile antigen, you do the best you can to predict what's going to happen in a pandemic, but cross-protection enables you to still make that antigen available and hopefully get an effective immune response. So adjuvants really help us increase the immune responses, but they have their cost as well, and it is certainly true that adjuvanted vaccines result in a higher rate of local and general reactions than unadjuvanted vaccines. What you see in this graph is a comparison of the ASO3 adjuvanted H5N1 vaccine in the gray side of the graph to Fluarix, which is our licensed trivalent influenza vaccine on the blue side of the graph. And it looks at a number of different common vaccine reactions. I'm not going to belabor the point. In darker green, you see those 18 to 60 years of age, and in the lighter green, those greater than 60 years of age, and in red are the grade 3 events. So the point I wanted to make here was that it is true that for every reaction, nearly every reaction, the reported rates are increased in the adjuvanted group. However, these tend to be mild to moderate. They're self-limited. And what you can see in the red below, it's really very infrequent that we observed grade 3 events. I think the other important point is if you are 18 to 60, you certainly have a more robust immune response, and you also have a higher reported rate of adverse effects. And this really speaks to how the adjuvants work. So they activate the innate side of the immune system. They activate that side very quickly, and that's why we see the reactogenicity in the first week after vaccination. But so now I want to talk a little bit about the future, because a few people have mentioned the desire for a universal flu vaccine, and GSK and others are working on this hopefully potential future product. So the influenza virus, and I should have said the hemagglutinin antigen of the influenza virus, actually has 2 components, the head and the stalk. And the immune responses we see to seasonal vaccine and pandemic vaccine are really due to the head. It's a very immunodominant antigen. But the epitopes there are highly variable. That's really responsible for the year-on-year antigenic drift. But the stalk within an influenza subtype is really well conserved. And so the belief is that antibodies to the stalk may be able to induce broader cross-protection, but you have to overcome that immunodominance of the head. So at least in our company, what we are doing is creating protein chimeras. So we take a head that humans have not been as frequently exposed to, say H5, and so I'm showing that in green in the formulation 1, and you put it to the N1 stalk. And in a vaccine, we would obviously want to have multiple strains, another representative A strain for H3 and 2, a B strain, but for the sake of example, I use the H1N1 here. Then 3 weeks later, instead of giving the same chimera, you switch out the head part of the protein to another exotic form, maybe H8. but you keep that same stock. And so what you see is that while you're still making new antibody to the head, in the stock, you begin now to overcome that immunodominance because you've been primed. And then you come to a booster dose with a third exotic head, and now you're really seeing an amplified immune response to the stock antibody. So we currently have a first-time-in-human study ongoing. The recruitment in that study is now complete, and we hope to report out by the end of next year. And I should say the NIH is actually also working on a very similar strategy. So their strategy, rather than using the exotic head, is to take the stock and apply that to a nanoparticle and inject that. And their first-time-in-human study is also ongoing. So I wanted to end with this quote, because we really in industry do see ourselves as your partner. I think it's been reiterated multiple times how much appreciation we owe you for the tough decisions and frontline actions you have to take. But we really see ourselves as a key player in planning for the next pandemic, and points have been made about the importance of relationships and communication. And I think the more we know about what you're worried about and what you're thinking about and how you envision preparedness in the future, the better we can also develop products to anticipate that need. And so then I finally wanted to end with a thank you. So Isaac Newton said, if I've done anything great, I'm standing on the shoulders of giants. And I certainly am standing on the shoulders of giants today. So the literally thousands of people who contributed to vaccine development, not only at GSK, but at the other vaccine manufacturers as well. Certainly our public health agencies who we work with in partnership, and regulatory agencies to make these products available. And then finally, all of you. I think the role you play has been reiterated multiple times in this discussion, so I won't belabor it. But as not just someone representing industry, but a citizen of this country, I really appreciate the work that you do. So thank you.
Thank you, Dr. Miller. So moving from medical countermeasures into non-medical countermeasures, Dr. Santos-Segura has joined us, and we'd like to hear a little bit of your perspective from your time as Director General overseeing the non-medical based response in Mexico during the early days of the H1N1 outbreak.
Which microphone? Well, thank you very much. I'm sorry for being late, but I was teaching, and so my dean tells me I have to teach. So I do that. Okay. Very briefly, this is a life experience that I want to share, and I basically will tell you what happened, why it was done, and what lessons for public health I think we can draw from this. This is my perspective. This is not the perspective from when I worked at the Ministry of Health in Mexico, and I'm not sure how much of this is applicable to the United States, but I think many issues are. What happened? This is what we were seeing. Suddenly, we saw in April, started to see an extended and increasing period of influenza. That was not seen in Mexico. This is not what happens. In fact, this is the hottest season in the year. This is Holy Week. This is, you know, the period of holidays. Usually it's very hot in this time. So why are we having this peak? So we started an increase in intensified surveillance in April. What were we seeing? We were seeing really atypical pneumonias with a very high lethality, 8% lethality at hospitals. So at hospital, they were calling us and saying, hey, people are dying. It was not really the surveillance system that really detected this. It is really the hospitals, the clinicians that called the surveillance system and said, hey, people are dying. Who are dying? Young adults, pregnant women, and really obese, very obese people, And in Mexico, as you know, we have an epidemic of obesity. So these are rare, not in the typical time, lethal, young adults, pregnant, and obese. So this was a collaboration between CDC, PHAC, and Mexico. We share the virus and try to identify it, and eventually we identified in April 23rd, we identified a new virus, a novel virus that had the pandemic potential. Who detected this? Well, I have to say the PHAC laboratory was the one that first gave us the description of the genomics of this virus. So it was a novel virus. Immediately, decisions were taken to close schools in Mexico City. This was happening in Mexico City, and it was the initial alert, and we introduced 7 personal hygiene protection actions. Sorry, these are in Spanish, but how to clean your settings, how to protect your sneezing, don't touch your face, stay at home, wash your clothes, wash your hands, and don't spit. Easy. Don't do it. Just don't do it. Okay? But the thing kept on growing. And Mexico City, as you know, it's a big city, a lot of people, lots of traffic. So suddenly this happened. From one day to May 1st, the city was stopped. And we had, in Mexico, it was defined an extended holiday for 5 days. The whole metropolitan area was stopped. May 1st is a holiday, it's Labor Day. May 5th is also a holiday. So the president said, let's have holidays for everybody. But you have to stay at home, okay? But you have to stay at home and do it, okay? So generalized closings. Schools were closed, restaurants were closed, churches, mass transportation, cinemas, theaters. So you cannot go to the cinema. So this decision of closing was very hard. But the next question is, how do you open? How do you reopen things? So basically, the industry, the non-essential industries, the non-essential services were closed. And then they said, okay, how you are going to open. So we started to develop a set of guidelines based on environmental interventions and all these 7 interventions on how you would be starting to come back into these different settings. There were some specific areas, so like outpatient areas for primary care, that were pretty difficult to handle. But by the way, there was an election, a midterm elections in July. So there were political gatherings. And we told the politicians, no more political gatherings. Believe it or not, they were stopped. So what is the benefit of this? Okay, really, what we wanted to do is, we had a novel, new virus. We had no idea about the potential. We saw at the hospitals that they were dying, 8% lethality. So really, it was a big concern. So we had to take decisions, and we wanted to take time, to have time to do something about it. So we said, okay, let's mitigate this. Let's try to reduce exposure. Let's try to reduce the over-demand on medical care. The healthcare services were really crowded. Let's reduce the transmission, and let's see if we can reduce the medical complications. We had no idea how to treat this. We had no idea. And the vaccine, we had run out of vaccine. And in fact, we asked JSK for the old vaccine, can we get it back? Because what are your stocks? And we built we said, okay, let's try to reduce the contact, and let's try to reduce the contagion, and let's see what's the distance between people that is safe. We measured that. We took samples and say, okay, when you talk, how far we can be to be safe. We defined it with 2.25 meters. Restaurants loved it. Okay, so we developed a set of technical criteria, environmentally based. So I am not an infectious person, I am an environmental epidemiologist, so I did my exposure assessment and did my technical guidelines based on this. And we published the technical basis for this, and all this technical basis was the support for all the different interventions that we had, and all this was basically distributed in different, very quickly, to different media, posters, guides, web pages, leaflets, bulletins, TV, radio, all over Mexico. We were targeting the total population of 110 million people. We had this image, PROMI. PROMI was an image that we developed in 2005, 2006, when we were doing our initial tests on how to cope with a potential pandemic of influenza. So we developed this, and it was very well accepted by almost everybody. And this is what happened. So here you have the epidemic curve. This is the first epidemiologic alert in April 16. You have the abnormal extended influenza. Then on April 24th, the closures. The extended holiday here on May 1st. The curve started to go down very quickly. We started to reopen schools here, and after the schools really started after Mother's Day on May 11 to open. Okay, so really a huge impact very, very quickly. The question is, okay, that's what we did, how it was done. Okay, in the morning, we had this conference call at 3 p.m. We said, hey, what do we do with this? Let's discuss it with the Minister of Health. We met with the Minister of Health, and we said, and the Minister of Health said, we have to discuss this with the President. And we went to the President immediately. And in half an hour, we drafted the note to the President in the car from the office of the Minister of Health to the office of the President. We met with the President, and people said, hey, is there a plan? Is there a pandemic plan? Where is the plan? And yes, we had a plan of 2006 plan, and this was 2009. And this plan was developed by the previous administration, okay? And I happened to have been in the previous administration. I was the only one surviving from the previous administration. So the president called the national cabinet and met with the different representatives of the cabinet. We drafted the communication lines, and the address to the nation at 11 p.m. was done, announcing that we had this epidemic of pandemic potential, and the closures were starting. So here is the Minister of Health. Basically, this was the first stage. The metropolitan area is 21 million people, so it's a considerable amount of people that we decided to address. The plan was established in 2005, and this is a first important message. It was part of the global collaboration on building this plans, rehearsing, trying to learn from each other, and GSAC was very important for this global collaboration. And we were in charge of the communications and the coordination of all these measures. But What was not in the plan and that we needed? We needed not only the political support, but we also needed the legal authority. This is very important. So in the case of Mexico, the Constitution we have a constitutional right. We have a constitutional right to protect health. So health is protected in the Constitution. So the president, in the case of a national threat, this was considered a national security issue. And the president gave to the Secretary of Health, gave the authority to act under this. These were the principles that the president gave. The first principle is to protect health and preserve life. That was he said, this is the most important. We know this is going to affect the economy, but the economy is second. Social, economic, cultural, and political life continues as possible, and those were his words. Okay, so this is very important. The principles that we followed were these ones. So we have these methodological challenges. We had to base in risk analysis. The policy principles, we had it from the president, we had the technical criteria, but we had to implement this. How we would implement this? Well, we had several platforms. One is the health system itself. We had a health promotion model with health promoters throughout the country. And we have had several years of developing health promoters in the country at every health district. Professionally trained health promoters and technicians. We had about 2,000 of these. We had a new regulatory agency. We had an expanded primary care system and certainly a strengthened surveillance system. We had an intersectoral platform with schools, with work sites, and with municipal authorities. Almost done. And this is very important because we met every 6 months with basically most of the municipal authorities at the federal level. At the regional level, we had periodic meetings, and the contact was very frequent, so we were able to get very close. We had other contacts with different levels, and I will not go into details. Running out of time. Let me just say that we were able to concentrate. Initially, everything was done for the whole country, but later on, we decided that we have to fine-tune the interventions depending on the health district. In Mexico, there are 236 health districts, and we developed a tool for this, and we were able to differentiate the interventions and intensity of interventions by health district and follow up on all of them. Okay, so what lessons, and this is my last one. What lessons do I draw? First, political coherence. So there is a political decision, and everybody follows. And I think it was very important. And here the idea is stewardship by the state to protect the life. And this was reflected in the law. And I think that was very, very important. The public health system, the functions were developed, and this was critical in order to do this. We had several platforms that we could use. We were prepared. We had this plan. It was there. But it was, there was a health authority that was empowered. No question about that. We felt empowered. We felt that we had the support all over to the top. And I think this was extremely important. So this is the experience, and this is what I can share of what we need, I think, in general for these interventions. Thank you very much.
So we have about 10 minutes for questions for our panelists. So I'll open it up to the audience. There are microphones going around. I think Dr. Dreisner may have a question. Maybe as the microphone is being passed, I'll start with one. Oh, maybe not. We have someone ready now. Oh, please.
Hi, Stephen Pont, now with the Texas Department of State Health Services. However, during H1N1, I was the medical director for Austin Independent School District, one of the first school districts in Texas that was directly affected by H1N1. So very much enjoyed the conversation, and perhaps for the current panelists or for the previous ones, I was just wondering, as far as the advancements for active syndromic surveillance, in that in Austin, when it first came out, we had a 10% fatality rate reported from Mexico, and we're very fearful of that. However, with our systems in place in Austin that were more paper-based and working directly with our school district, we were able to collect real-time data to know, are kids absent? Are they really sick? Are they at home ill or not? And then work back with our hospital, which was the collection area for the region, to know. I could talk to my colleagues in the emergency room. Our kids coming in, we had CNN there, we had tents out in front of the hospital, and but it was all walking well. They weren't really ill, they weren't getting admitted, and they weren't dying. And if they were to die, we would know almost immediately if they were dying. And so with that active surveillance, we were able to work in collaboration with our current commissioner, Dr. Hellerstadt, who was the chief medical officer of our hospital at the time, and then our Dr. Lakey, who also was here, and he was the commissioner at the time, and we're able to avoid having to shut down our school district. So long bit of history, but then also just now, where are we now as far as real-time surveillance in the U.S. and then with our sister nations where H1N1 or the next one might come from, to get that closer data to know sooner rather than later the virulence of these new novel infections.
Okay. Any of the panelists or Dr. Red?
How about Dr. Red?
The question, I think, really gets to the heart of the challenge of the specificity of our surveillance tools, from the worried well to dead. That's a big clinical spectrum.
So I'm going to give a slightly narrower answer to that question. We have we've moved to we now have the capability 24, 48 hours. About 2/3 of emergency departments are reporting data that are available. So very much improved. I mean, it is one of the major accomplishments that's taken place since H1N1, is that we've got systems that can give us information in very close to real time.
Great, thanks.
Thank you. Did you have a question? Can we get a microphone for Dr. Dreisner for the unseen audience? Thank you.
We talked a minute on the last panel about the universal vaccine, and you get mixed answers about where we are depending on who you asked. But I'd love to know from your perspective as somebody who's in the industry, where are you?
So that's a tough question when your first time in human study hasn't reported out yet, but I would say I'm cautiously optimistic. So I think that we know that it may take some tweaking to get the right formulation of the vaccine. We're actually testing quite a number. I simplified a bit the slide for the considerations of time. But I think if this stock idea really is going in the correct direction, there are multiple groups working on that same idea. And so the hope is that if we can find an antibody to something that is more cross-protective, we can vaccinate in a time like now that's an interpandemic period, and we'll have some cross-protection on board. That doesn't negate the possibility to then also give strain-specific immunization during the pandemic. And I think it speaks a little bit to a comment that was made earlier that maybe we need to do more to help people understand that it's not really a once-and-done kind of infection, and there may be multiple strategies that will complement there. But maybe if we have this discussion, maybe not quite in another year, but another 2 years, I can give you a more specific answer.
Sure. Well, I love the challenge, right? Universal flu vaccine. I'm like, that sounds like us. But if you I think so. Dr. Red made a really important point to sort of, we could have the best response in the world, and it's about the virus. It's not about us. I mean, that every time we think we got flu figured out, it takes one step. Does something different, right? So that's a worthy adversary, if you will. I think, but but just one of the other things to highlight for this audience that I really liked about that HHS plan, that and I'd encourage everybody to read that it's, it's not just about finding the right vaccine that produces the right immune response that gives that duration of protection. It's a critical component. But they also talk about a lot more natural history studies, this understanding of if you had influenza a long time ago, does that influence how you respond to influenza now? And it makes a lot of emphasis, too, in terms of improving our ability to do clinical trials. I think where we always fall down is, and you guys can certainly back me up on this, is that we do these highly regulated clinical trials in a set population under these perfect conditions, and then we do the perfect comparison, and we get P.04. Great, we saved the patient, and then the products fail in the community. And so I really think we as a community need to embrace this idea of much broader clinical trials, that figuring out how we do electronic informed consent, how we can enroll communities of patients, how we can, why can't we do 1 million patients in a major metropolitan area as a clinical trial this upcoming flu season? Like, if you really think about technology enabling that, and making sure it's all ethical, making sure it's all regulated. But truly, if we're going to and I think the NIH and the CDC, part of the plan for the universal flu vaccine is not just put all your money in the vaccine, it's put your money in all of the apparatus that we truly need to be able to assess, how someone is protected from influenza. Really good diagnostics. I mean, that's where the ultrasound idea comes in too. Are they actually sick or not? I see that we as a community, if we do all of that part better, then once we have even a slightly better vaccine, we'll truly understand it.
Okay, I'd like to actually move us into lightning rounds of the match. We have about 3 minutes left. I was actually going to go to you at the microphone, then over to Dr. Levine, and then back if we can keep the questions short and the answers crisp.
My name's Natalie Thrasher. I'm a grad student here at the Milken Institute. My question goes across the panel, but specifically in regards to DARPA. Admiral Red brought up the concept that we need to challenge those implicit assumptions. And so I'd like to hear sort of how does DARPA do that in going forward, either picking what they're going to fund or just like to hear your thoughts on that.
Yeah, concisely. But for this audience...
That's an hour-long grand rounds, I think.
So there's lots of ways, but I think the fun part about being at a university is that the next generation will do that for us, and this is why those that educate the next generation do such an important job. But the next generation needs to say, yeah, but a lot of the things that you're teaching me, really, what is the basis for that? What's the dogma that goes behind it? Because you know what, a lot of our assumptions are fundamentally wrong. Biomedical research, we need to fundamentally change a lot of things about how we do that process. And the next generation is the ones who are going to be able to do that. It's not me, I'm set in my ways. I am, well, kind of. I mean, DARPA can't be as set, but no, I think there's two answers. The first is the next generation needs to question all the assumptions and use all the new tools available, technology, et cetera, to relearn and make more progress. I think the second part is that the point I was making at DARPA is that, we who are infectious diseases and public health experts provide that subject matter expertise. But why aren't we using the computer science departments and the math departments? And, really, we see a lot of these multidisciplinary approaches, which I think are awesome. They occur at universities. We mandate that when we say you're trying to solve a complex problem. But I would say for the public health community, please start reaching out more and more to the AI people, the machine learning people, and who are looking to apply their skills to solve our problems.
Okay. And Dr. Levine, can you finish this up?
Thank you all. I was really struck by all your presentations, and this will be a follow-up to the prior question. But what struck me about all three of you is that all of that work required incredible teamwork, and I was interested in perhaps a comment about the environment that you were all in that actually stimulated and supported creativity and innovation, which I think is at the root, particularly for the first two talks, but you had to be creative and innovative in a political environment. So I think that's something that we don't talk enough about, and I wondered if you could just comment on how that showed up in your arenas.
Sure. So I will say that it was not only within our company, and I suspect within other companies, where there was a clear priority made to work on this program. So I mentioned that I had previously been working on another program. That program was actually set behind so that I could be freed up to do that, and that happened across the company, that we decided this was a global problem, and it was our problem, that the infection we might be preventing might be our own. But I think even in the external environment, the willingness to kind of work together with regulatory agencies to figure out what data do we need to generate to be comfortable to do this, but not take so long and be so overly cautious that by the time we get there, we're going to have missed the outbreak entirely. And I think the discussions with public health about what do you really need. So here's an example. One of the things when we're looking at different dose ranges, the clear message from public health was, yes, dose ranging is important. Yes, if it's safer to give a smaller dose in children, let's do that. But let's also remember that we're doing this in a very chaotic environment where there's a lot of stress on the system, so it also needs to be easy to implement, which was also a driver for the half dose in the pediatric population. And I guess creativity is something you have to foster all the time, right? So I want to compliment on the activities that DARPA is looking into, because we also are foraying into electronic informed consent. We're looking for ways to increase the diversity in our clinical trials, because we know that not all populations respond the same. We're looking for more novel ways to conduct our trials so that we don't have to take so long to enroll, but we still have the right controls in place so that patient rights and safety are respected. So I would say it's a day-to-day thing, and hopefully everyone works in an environment where that's encouraged. I'm certainly fortunate enough to do so.
All right. Well, that's a great note to end on. I want to thank everybody for your participation today. We may have lost the web audience, but if not, thank you for joining us today, and join me in thanking our panelists once again.
I'll give you a card. From me, no.
We partnered with.
They're still using it.